All right. So thank you everybody for joining this afternoon's MBQIP open office hours. We have Ann Logus of RQITA, Telligen, and Courtney Ryan. Ann and Courtney are both senior quality improvement facilitators with Telligen. This afternoon, they're going to talk to us about the future of MBQIP and are you ready? So ladies, if you'd like to take it away, we'd be happy to hear your presentation.
Great. Thank you so much, Amanda. Good afternoon, everyone. First, we'd like to just start off by saying Happy New Year to all of you, and thank you so much for inviting us to meet with you to kick off 2024 with a presentation on the 2025 MBQIP measures. As Amanda just mentioned, my name is Courtney Ryan. I'm a Senior Quality Improvement Facilitator with the Telligen RQITA team. And joining me this afternoon, I was going to say this morning because it's morning here in Denver. Joining me this afternoon are a couple of my amazing peers, Ann Logus and Elena Brotherson. Ladies, would you like to just come off mute for just a moment to introduce yourselves? We could start with Elena.
Hi, everyone. Elena Brotherson here. I'm lead quality improvement with the RQITA team, and it's great to be with you all today.
Hi, my name is Ann Logus, and I am in Iowa in a blizzard and happy to be here with you though. So I'm one of the TA facilitators that is available to Amanda and to hospitals to work through all of these new measures. And it's just really nice to be here with you today. Thanks for having us, Amanda.
Thanks, ladies. So just a couple housekeeping details. Everyone will receive a copy of the slides. And as we go through the presentation, please just feel free to chat your questions in any time. That way you don't forget them. And then we'll be sure to address them at the end during the time that we've built in for Q&A. So thanks again for having us and for sharing a part of your day with us. Next slide, please. So our objectives for our time together over the next hour will be for you to be able to identify the 2025 MBQIP measures, to hopefully have a better understanding than you do right now about the various data elements, submission mechanisms, and deadlines as it relates to each measure. We're going to take a few minutes at the end to review the submission mechanisms for OP22. And then peppered throughout the presentation, we'll be sharing resources for each measure to help support you in being successful. I do want to note that we've intentionally developed this presentation slide deck so that it can be used as a reference resource for you to utilize. So having said that, we recognize that some of the slides might feel a little content heavy, and there are quite a few of them. But again, that was purposeful on our part so that you have something moving forward to review and re-review as you need to. Next slide. So in case you're not familiar with Telligen, we have around 50 years of experience working on contracts at the federal, state, and local levels. Our Telligen team is vast and diverse with over 600 clinical and technical professionals working hard to carry out our mission, which is to transform lives and economies by improving health. And lastly, we are an employee-owned company based out of West Des Moines, Iowa, and have additional offices in Colorado, Oklahoma, and Illinois. Next slide. So while our Telligen team has over 600 members, our RQITA team is small, but we're small and mighty, as they say. We're very excited about this work and learning how we can best support all of you. So if you start in the upper right-hand corner, we just met Elena. She's located here in Colorado and will serve as the lead QI. Going clockwise, Ann Logus, we just met her, and she just mentioned she's in a blizzard. She's located in rural Iowa and will be providing technical assistance and support. Meg Nugent is our program director, and she is located in North Carolina. Susan Buchanan is our senior director, and she's located in Iowa. And then that's me in the lower left-hand corner under Elena. I'm also located in Colorado alongside Elena, and we'll be helping to provide technical assistance and support with Ann. Next slide. So the focus of the Rural Quality Improvement Technical Assistance Center, or RQITA, is to improve quality and health outcomes across our rural communities by providing that technical assistance and resources to support the CAH success in the MBQIP project. Our team is here to complement and add expertise related to quality reporting and quality improvement. We are not intending to replace the support that you already have in place. You can see on the right-hand side of the slide the resources and services that we will work to bring you, which includes a monthly newsletter, up-to-date resources, guides and tools, one-to-one technical assistance, learning and action webinar events, recorded trainings that you can access on demand. And then the last bullet here includes a hyperlink to the Task Rural Health Center website, which is just full of all sorts of resources and tools. And then just to get a little more specific on what that assistance looks like, we can provide support around measure information or specifications or deadlines, data collection assistance, reporting application assistance, if you need help with accessing and sharing your FMT reports, or perhaps analyzing those reports for the purposes of quality improvement, and then just general quality improvement assistance as well. Next slide. So as we get started, we thought we would just take just a couple minutes to just kind of level set with a quick MBQIP recap. Next slide, please. And we wanted to start with just highlighting some of the benefits for the importance of participating in MBQIP. So I'd like to just start by saying that improving quality of care across our rural communities is really the core of why we all do what we do. We all have our personal reasons of why living and working in rural America is so important to us and why we're so passionate about what we do. And so one of the most important benefits in participating is for you all to be able to showcase your story, to show your work and to demonstrate the value and the quality of care that you deliver in your communities. You want to be the place to go for your community member healthcare needs. And I feel like there's just no better way to communicate that than by being able to share what you do and how well you do it through your continuous quality improvement efforts and reporting programs. Participation in MBQIP affords the opportunity to link arms with your rural peers in shared goals and quality improvement initiatives that can really help to just forge those peer-to-peer learning and mentorship opportunities, improve patient experiences, and empower better and more informed healthcare decisions. MBQIP also establishes a common set of rural relevant measures that foster the implementation of quality reporting processes, helps to build your quality improvement skill sets, and provides data that leads to actionable next steps, which then helps to support this next bullet of increasing your capacity to participate in other federal and state programs like the value-based purchasing programs. In fact, many of the benchmarks for the measures in MBQIP are those of the value-based purchasing program benchmarks, with that intent to sort of give you all kind of a sense of that North Star, so to speak, of where you are in relation. You also can you have access to Flex program resources and subject matter experts to provide support that meets you where you are. And then lastly, MBQIP aligns with the CAH conditions of participation as a quality improvement activity under the Flex program. Next slide. So this slide shows the current core MBQIP measures under the 4 domains that you see here, and I know you all know these very well. These include the immunizations for healthcare personnel and antibiotic stewardship, your HCAHPS measure, the EDTC under care transitions, and then the 2 ED measures of OP18 and OP22. And as you all know, again, and can see in the italicized note that OP2 and OP3 were removed after the submission period for Q1 last year as part of the annual rulemaking process. Next slide. So each year, the Federal Office of Rural Health Policy, or FORP, has an annual rulemaking process where they will discuss the removal of measures and the addition of measures for consideration. And if you remember just a couple slides back when we discussed that one of the MBQIP participation benefits was the opportunity to prepare to participate in other federal reporting programs. So this is a demonstration of that, where wherever feasible, they are working to align measures with for MBQIP with other federal reporting programs. And that's what they've done here with the 2025 measures. So during that annual rulemaking process, those opportunities to align type of conversations take place, along with incorporating the feedback that they get from all of you during the open comment periods, and then ultimately determine the core measure set. Next slide. So here's what the MBQIP timeline looks like. So for this year of 2024, hospitals will continue reporting the existing MBQIP core measures as you've been doing as part of the FLEX program. During this year, though, it is also our time to really begin to prepare to participate in reporting on the 2025 MBQIP core measure set. So we encourage you to begin to put processes into place so that you are prepared to collect and report data beginning next year. It's also recommended that you not only have the processes in place, but that you go ahead and practice collecting and analyzing that data now so that you have plenty of time to work out any kinks in your processes, improve on the measures themselves if that's necessary. So just really taking time this year to set ourselves up for success, and just know that we're all here to help you along with your Michigan Flex program team with this transition. So don't feel alone, lean on us for support. And then in 2025 is when you'll begin reporting on the new MBQIP core measure set, and when the state Flex programs will start to track the non-reporting hospitals for the 2025 MBQIP core measures. So if for some reason you're not reporting, you'll want to connect with your Flex coordinator and talk to them about the barriers and challenges that you're experiencing, because that will just help inform how we can then provide technical assistance and support to help mitigate those challenges. Next slide. So this is the same information that was presented on the previous slide. It's just in a more expanded time-like visual. So the blue color indicates our activities from last year in 2023, and again this year in 2024 to plan and prepare for reporting. The gold in the middle is where we will begin reporting in September of 2025 on the measures and start our collaborative and state-specific quality improvement projects. And then as we move into 2026, shown by the green color, we will continue our reporting and submission processes that will have begun back in September of 2025. We'll continue our QI efforts, and then in November, the state Flex programs will submit their end-of-year report along with a list of any CAHs that did not report during that time frame. So that time frame would be from September 1st of 2025 through August 31st of 2026. So again, if you're not reporting, please have those conversations with your state Flex coordinator so they can better support you. Next slide. So with the addition of the new measures, we will be moving from 4 domains to 5, and those domains will be global measures, patient safety, emergency department, patient experience, and care coordination. So again, the new measures will align with other existing reporting programs, and we just noted on the previous timeline slides that reporting for these measures will begin on September 1st of 2025. Next slide. So this slide provides a quick visual of the 2025 MBQIP core measure set as a whole. So the new measures are listed in blue color, and we're going to review each of these in detail today. And the existing measures are listed in the green color. So as you can see, there are 6 new measures, which now gives us a total core set of 12. Of the core set of 12, 9 measures will be submitted annually, and 3 will be submitted quarterly. And you'll note that all 6 of the new measures are reported annually. So the ones that are reported quarterly are the ones that you've already been reporting quarterly already. So under the new domain of global measures, there are 2. We have the CAH Quality Infrastructure measure and the Hospital Commitment to Health Equity. Under patient safety, there is 1 new measure, which is the safe use of opioids. And under the care coordination domain, there are 3 new measures: the hybrid hospital-wide readmissions measure, the social determinants of health screening measure, and then the social determinants of health screening positive measure. So now that we can identify the 6 new 2025 MBQIP measures, I'm going to turn it over to Anne to walk us through the data elements, submission mechanisms, and deadlines for each of the new measures. Anne, I'll turn it over to you.
Great, thanks, Courtney. And I just want to start by saying this might be the first time you've heard about the new measures, but I want you to kind of sit back and just listen to us and know that on some of these slides, we have saved most of, we have the information for you. We have the resources for you. Like Courtney said, it's very content heavy. So don't worry about writing things down and trying to write down resources. We've got it all right here. So I just kind of want you to sit back and just listen to the descriptions of the measures. Definitely write down questions. But just know that we've saved a ton of information in this slide deck, so you can kind of relax a little bit in regards to that. So let's just jump right in then and look at the first new measure, the CAH Quality Infrastructure Implementation Measure. And I'd like to start off by saying, if you have completed the National CAH Quality Inventory and Assessment with Amanda's help, you've been receiving notifications from her, I know, to complete that. If you've done that, you have already successfully submitted the data for this measure. So that's something you can check off and that you have completed and you're done with that. So let's move to the next slide here. And so I'll preface that by saying there's two separate items going on with this. There's the National Quality Inventory and Assessment that you completed. And then there's the CAH Quality Infrastructure measure that goes along with it. The measure is a structural measure, meaning that its goal is to measure the environment of quality improvement in your organization related to administrative processes, policies, practices, and guidelines in place, which I'm sure you recognized when you completed the assessment. The specifications for this measure will be released in 2024 as they're dependent upon the information that you submitted in the assessment. I'm sure these elements look familiar to you when you took the assessment. The elements are leadership and responsibility, quality embedded in your organization's strategic plan, workforce engagement, culture of a continuous improvement through behavior, culture of continuous improvement through systems, integrating equity into quality practices, engagement of patients, partners, and community, collecting meaningful and accurate data, and using data to improve quality. This measure will provide the results of your assessment and the measure. Will provide state and national comparison information to assess your infrastructure, your quality processes, areas of improvement for each facility. Using this measure, state flex coordinators can plan quality activities to improve processes and patient outcomes, and data will provide timely and accurate, useful quality related information to help inform the state, but also the federal partners as well. So this measure will be broke down into state level information, hospital level information, and program wide information as well, so that we can set technical assistance baselines, benchmarks, and assess the quality needs that exist. The calculation that will come in the specifications are the hospital score will be a total of 0 to 9 points, 1 point for each element, and it must meet the element's criteria to receive credit. Next slide, please. The measure submission and reporting channel. So you've already done this. The annual submission through the National Quality Inventory and Assessment was done via the Qualtrics platform. So again, I'll just reiterate, if you completed the National Quality Infrastructure Inventory and Assessment, you have successfully submitted for 2023. That is completed. Then this slide shows resources that are available to support you. Like I said, specifications for this measure will be released mid-year 2024 and are being informed by the results of the assessment, which you have already completed. Amanda will share more information with you when this measure when it becomes available. And we are also here to assist you with any questions you might have. You will not find information on this measure or the assessment in QualityNet or on CMS Gov sites, as it's very specific to MBQIP. So if you are looking for a link or any information, come to us, come to Amanda. You're not going to find it on national websites. Next slide. So the next slide is another new measure, and it's categorized as a global MBQIP measure called the Hospital Commitment to Health Equity. Next slide. And this is a brand new measure from CMS as part of the Inpatient Quality Reporting Program. It is a structural measure, meaning it's measuring the environment and does not require abstraction of individual patient records. This measure is reported by answering questions attesting yes or no to whether or not activities or processes are performed in 5 different domains. Each domain that you can see here on the screen is also comprised of a number of subdomains. As an MBQIP hospital, you would enter the information into the hospital quality reporting system and then answer the questions provided yes or no for each of the questions. I'll break down this for you in the next few slides, and you'll also have a lot of great resources and a link in a future slide as well that details and describes each of the domains. So I want to mention that other hospitals, not critical access hospitals, other hospitals in the IQR are also reporting on this measure. And if you look in QNet or CMS websites, it may mention reporting deadlines for them. Those deadlines are associated with the inpatient quality reporting deadline. And MBQIP hospitals can begin to report this measure, but for MBQIP purposes, your deadlines or your recommended time to initially submit this measure will be associated with documents from Amanda and MBQIP. So when a CAH is looking for deadline submission information, always refer to your MBQIP documents provided by Amanda or RQITA. Next slide. Let's see. Let's see. I'm going to move to the next slide. I might need to come back to 21, but I'm going to jump to 2022 as we kind of break down each of the different domains. So domain 1, equity is a strategic priority. So remember, there is 1 point for each domain, and you must attest yes to all subdomain questions. So there's no partial credit. You must attest yes to all 4 questions here to get 1 point for domain 1. These elements are really common in quality improvement, and you are acting on many of them probably already now within your regular quality improvement processes and goals. For example, domain 1 or subdomain A, reviewing your quality data and identifying a target population that is experiencing poor healthcare outcomes at your facility. Subdomain B, identify action steps and interventions to help target the patients experiencing poor outcomes. C is associated with identifying resources to support interventions and goals. And D is associated with pulling together teams, partners, and stakeholders within your facility and community. So as I mentioned, you're probably doing all of these activities already within your quality improvement processes, but what's different for this measure and domain is that it focuses on moving these quality improvement elements that we know as quality improvement professionals and moving them into the hospital's strategic plan. Next slide. Domain 2 is associated with data collection. So it includes collecting demographic information directly from patients, offering training to staff for collecting the demographic information, and inputting this information into structured, inoperable data elements using certified EHR technology. This domain is collection of demographic and social determinants of health information and inputting them into the EHR, meaning that this data could also be pulled out and into reports that you and your quality teams and leadership can use to analyze your patients and help identify target populations in most need of improvement. So the first encounter period, or reporting year for participating in MBQIP hospitals is calendar year 2025. This domain may take some extra collaboration with your EHR and IT team and IT support systems. So just make note of that. Domain 3 of the hospital commitment to health equity measure is about data analysis, using the data collected as mentioned in the previous domain. And the next step is performing effective data analysis, as it can provide insights into which of patients your quality improvement efforts need to focus, and what factors may be contributing to their health outcomes that your facility and community need to respond to. Hospital quality improvement processes typically include data analysis. We know this as quality improvement professionals. You're looking at key performance indicators, such as, for example, readmissions and hospital-acquired conditions, and deep diving into the many patient variables to find trends, to identify the patients that are having poor outcomes in your facility. So domain 3 ensures that patient demographic and social determinants of health information are included as one or two of those major variables that your hospital chooses to analyze and put on dashboards. Domain 4 at the bottom of the screen here is quality improvement. This domain encourages participation in local, regional, and national quality improvement activities focused on reducing health disparities, such as the rural health disparities that your facility may have identified as one that patients in your community experience. Next slide. Lastly, domain 5, leadership engagement, includes annual review of strategic plan and regular review of quality data. Next slide. The first encounter period, like I mentioned, or reporting year for participating MBQIP hospitals is calendar year 2025. Hospitals will gather information from multiple sources to confirm that they engage in the activities described in the attestation domains and subdomains that we talked about during the period of January 1st, 2025 to December 31st, 2025. If hospitals participate or complete qualifying activities at any time within that reporting year, they may answer yes to their attestation. Hospitals must complete their attestation for the calendar year 2025 reporting period between April 1st, 2026 and May 15th, 2026. And that is submitted through the Hospital Quality Reporting Secure Portal. Next slide. Here again are definitely a major slide for you to look at later and deep dive into these 4 resources for you. This first one here, really like to bring this one to your attention: attestation guidance for hospital commitment to health equity measures. This is an excellent resource that breaks down all the subdomains for you. I really encourage you to look at this one. And then rural health disparities overview, rural health addressing barriers to care, and of course the MBQIP 2025 information guide. Definitely encourage you to do your own research on all of these new measures, but sometimes I know you can get down a rabbit hole of resources, and I just want to bring you back to this slide to make sure that you're focused on the most important things at this time and the accuracy of your reporting deadlines, especially in that last one, MBQIP 2025 information guide as well. So we will now move on to the patient safety domain. Thanks, Courtney. And we'll move on to the next slide as well. Thank you. So we have our next new measure, safe use of opioids, current prescribing. Measure rationale here is that patients on 2 or more opioids have increased potential for adverse events, including overdose and death. This measure is calculated as a rate. It's looking at the proportion of inpatients 18 and older who are discharged or continued on 2 or more opioids or an opioid and a benzodiazepine. Next slide. The safe use of opioids is an inpatient ECQM. It's a current measure of the Medicare Promoting Interoperability Program, and it gets submitted annually with a deadline in February. It's submitted using the Quality Reporting Data Architecture, or QRDA, Category 1 file format via the HQR platform. The first MBQIP reporting period for this measure, and I may have jumped ahead here, but I'll repeat it, is January 1st, 2025 through December 31st, 2025, with a submission deadline of February 27th, 2026. We can jump to the next. Yep. So this slide describes abstraction details for you. It describes your measure population, some important exclusions, and your numerator and denominator, which I've earlier described. I won't read these for you, but you have this slide here, important to review again and look at as you're collecting information as you get ready to report this measure. And then the next slide is another important slide for you. As you look at this measure, these 4 resources will be extremely helpful to you as you prepare. And if you have questions when you're looking at these resources, the RQITA team is here for you. Amanda is here for you as well to answer your questions. But these are a great slide and resources to support your work. With that, we have some new measures in the care coordination domain. There are 2 measures that are kind of connected to each other. So this description, I promise, will go by a little fast. So thanks for taking in all of this information and stick with me here. So next slide. Oops, let's see. Whoops, I kind of got myself off. So screening for social drivers of health is a new CMS measure under the IQR program, the Inpatient Quality Reporting Program. The submission will be a numerator and a denominator that is submitted annually through the HQR portal. So you're not submitting patient level data, you're not using CART, you're not abstracting within the CART tool. It's submitting a full year of numerators and denominators. It's a percent of patients 18 and older admitted for an inpatient stay that are screened for all of the following health-related social needs. They're looking for these 5: food, housing, transportation, utility, and interpersonal safety. They are not specifying a screening tool that you must use, but you do have to capture all 5. Within the specifications manual, there is a list of suggested screening tools. And again, this is a new measure for everybody. The first available reporting timeline is spring of 2024. That would reflect patients admitted in calendar year 2023. So it's something that you would submit just on an annual basis, but it would be with percentages. Next slide. The recognition of health disparities and impact of health-related social needs has been heightened in recent years. Economic and social factors known as drivers of health are known to affect healthcare outcomes and cost. So this measure is derived from the Center for Medicare and Medicaid Innovation Accountable Health Communities model that has been tested in large populations across the states. The intent of this measure is to help ensure hospitals are considering and addressing social needs in the care they provide to their community. Next slide. Again, the numerator is the number of patients 18 and older that are screened for all 5 social determinants. You can use whatever screening tool you choose. And the denominator is total number of patients admitted that are 18 years and older. So you need to screen almost all of your patients, but there are 2 very important exclusions to keep in mind. Patients can opt out and does not, they can opt out and that does not go against your data, meaning patients can decline to answer the screening questions, and that is fine. You ask them the question, that is what you're supposed to do, and you document that they declined it. It will not go against your quality data. If patients are unable to answer, that also excludes them, and it won't go against your quality data as well. You just need to document that. Also, you are meeting the measure by screening the patients. There is nothing in the measure that says you have to do something specific with their answer. We know you are addressing them, but that is not part of the measure. Within the measure, it's not a count of what you did for the patients after they answered the SDOH questions. Next slide. So the encounter period is calendar year 2020, calendar year, January through December. The first MBQIP encounter period and reporting date is January 1st, 2025 through December 31st, 2025. And the submission deadline date is May 15th, 2026. You have here the calculations that I described, your numerators and denominators, and that it is reported through the hospital quality reporting system as well. Next slide. Again, resources to support you. Great slide to bookmark, as it's got a lot of great resources to keep you on track. And we'll just jump to the then the list of screening tools we popped out for you as well on there. Have a good look at that one as well. The next, the other piece, so to the social drivers of health, is that there's also an additional measure element to count, and it's an additional measure, separate measure, and that is the number of patients screened, that number of patients that screen positive to the social drivers of health measures. It's a new measure and would be reported the same way you do the numerators and denominators. So you would be looking at, the denominator would be the total number of patients screened, and the numerator would be the total number of patients screened positive. There's nothing here again about what you need to do when they screen positive. It is simply a count of the number of positives for each of the 5: transportation, food, personal safety, utilities, and housing. Can you go back one more screen? I just want to mention here, the bottom part here, improvement noted as this measure is not an indication of performance. So what we're trying to say here is that these patients that come in and screen positive, that is not an indication of the hospital's quality, because that patient may just have come in for the first time. We can explore this thought in the future, but the performance, proper good performance, is that you are screening them. Screening negative, if a patient screens negative, it's not an indication of poor performance upon the hospital. I hope that was clear. If you have any questions, we can go into that further later. Let's see. Yes, we're on the right slide. So to reiterate, this is a new CMS inpatient quality reporting program measure. The same exact exclusions apply if the patient opts out or is unable to report. When you look at QNet sites, keep in mind that the specifications definitely apply to you, but the reporting deadlines and recommendations for starting your reporting on this come from MBQIP. Next slide. Encounter period is a calendar year. And again, as with the other one, the first MBQIP encounter period and reporting date is January 1st, 2025 through December 2025. And the submission deadline date is May 15th, 2026. The result of this measure is calculated with 5 separate rates for each of the elements, each of the social drivers. Submission reporting channel, again, is the HQR platform as well. And again, next slide are the resources here for you. They're similar to the other social determinant of health measure as well. With that, I believe our next slide is for Courtney to take over. Thanks so much for your attention. And with that, I will hand it back to Courtney.
Thanks, Anne. All right, guys, one last measure. So it's probably no surprise that a focus on reducing readmissions continues to be strong under the National Quality Strategy and within all the various reporting programs. And so, as you probably know, CMS is currently using the hospital all-cause readmission measure in other reporting programs like the hospital inpatient quality reporting program and the Medicare Shared Savings Program. And so again, in that effort to align MBQIP with these other programs, we will now prepare to report on what is called the hybrid hospital-wide readmissions measure. So the description for this measure is that it is a hospital-level, all-cause, risk standardized readmission measure that focuses on unplanned readmissions 30 days of discharge from an acute hospitalization. And so if we unpack this description a bit, hybrid is basically a way of differentiating a measure from the claims-only measures, as this measure will merge electronic health record or your EHR data elements along with claims data to then calculate the risk standardized readmission rates. So ultimately, this hybrid methodology was developed to allow for a more comprehensive assessment of hospital performance in addressing those complex and critical aspects of care that could not be identified by just dissecting claims data alone. So it's a good thing because it allows us to do a deeper dive into improvement opportunities and the clinical aspects of care when it comes to readmissions for those complex care cases. The risk standardized readmission rates can be a little bit confusing and complicated, but essentially it's calculated through a formula and algorithm using unplanned readmissions within 30 days from index admission, and then again combining claims and EHR data elements, and then adjusting for differences in case mix and service mix across all the hospitals, again, kind of with that goal to be able to identify the critically ill patients that have a higher probability of readmissions, again, those complex cases, and then taking all of that into account when calculating the rate. Next slide, please. So when it comes to the rationale behind this measure, the impact that it has for our patients is pretty obvious. It's disruptive to their lives when they're readmitted. It increases costs on our healthcare systems and increases risks for healthcare associated infections and other adverse events. In addition, we're just really wanting to improve the communication.
Courtney, your sound dropped out.
Amanda, I don't know, we might have lost Courtney. Let me look down
Okay.
on my speaker notes and I'll pick up where she left off here.
Perfect.
Let's see. Yep. Let's see. So I'm not sure exactly where the risk standardized readmission rates can be a bit confusing and complicated, but essentially it's calculated through a formula, an algorithm using unplanned readmissions within 30 days from index admission, combining claims and EHR data elements or clinical elements, and adjusting for differences in case mix and service mix across all hospitals, and with the goal to identify the critically ill patients that have a higher probability for readmission. Again, those complex cases, and taking into account when calculating this rate. So the description, the logic is intended to extract electronic and clinical data. It is not an electronic clinical quality measure, and this logic will not produce measure results. Instead, it will produce a file containing the data that CMS will link administrative claims on the back end to risk adjust the hybrid rate. It is designed to extract the first resulted set of vital signs and basic laboratory results obtained from encounters for adult Medicare fee-for-service patients admitted to acute care short-stay hospitals. The initial screening population is, like I said, Medicare fee-for-service encounters 65 and older at the start of an inpatient admission who are discharged during the measurement period. All Medicare fee-for-service encounters meeting the above criteria should be included, regardless if Medicare fee-for-service is the primary, secondary, or tertiary payer. For each encounter, please also submit the following linking variables: the CMS certification number, health insurance claim number or Medicare beneficiary identifier, date of birth, sex, inpatient, admission date, and discharge date. And then,
Hey, Anne, I was able to join.
There you are. Welcome back, Courtney.
Gosh, thank you for filling in. I apologize. Ironically, I live in a mountain town where I have terrible internet service, but I actually came to the Denver office so that would not happen. So I really apologize. Okay, so on this measure here, we just wanted to highlight a couple things in that you may want to prioritize preparing to report on this measure. So notice the submission date and the encounter period. So the encounter period is July 1st of 2024 this year through June 30th of 2025. And the submission deadline is September 30th of 2025. So on July 1st of this year is when you'll begin collecting the data. This measure already exists and is available for reporting now. So definitely connect with your peers and get support so that this doesn't sneak up on you if you're not already in a position to report. And all the other new 2025 measures that we've been reviewing today will be submitted in 2026. So this is the only one that has that submission deadline of September 30th, 2025. So just make sure that you are doing what you need to do to prepare for this measure. Next slide. So these are some additional great resources to help you, and we encourage you to take out that specification manual and then just break that down into manageable sections to work through this. And again, as with all of the measures, and as Anne has mentioned a couple times, we're all here to help you along the way. Next slide. So this is just in summary, wrapping it all back up. Again, the new measures are the ones that are in blue. The ones that are in green are the measures that you've already been reporting, and the star indicates measures that are currently available for reporting. So again, prioritizing that hybrid hospital-wide readmissions measure. Next slide. So these remaining slides, I'm not going to go through each of these. We just really wanted you to kind of be aware of what is I just want to kind of quickly go through what's in the rest of the slide deck, but the rest of the slides are just intended to be resources for you, screenshots for you of how to walk through different things. So this slide here just shows a couple new resources that are hot off the press. We have an MBQIP 2025 information guide, a grid that you can quickly look at and see the submission deadlines for the measures. And then on the far right are some state flex program key resources. Next slide. And then one more slide again. So just wanted to shift gears a little bit for a couple moments as we wrap up our final objective on reporting the data before we go over to the Q&A. So this is just a quick visual for you for the reporting channels for each measure. You can see that with the exception of the CAH Quality Infrastructure measure, all of the other measures are submitted through the Qualtrics platform, or excuse me, all of the other measures are submitted through the hospital quality reporting platform. Next slide. This slide you're probably aware of, but just in case you're not, just wanted to make sure to put it on your radar and encourage you to bookmark this. This is the Quality Reporting Center. They have all kinds of great resources, tools, good information for you to have handy. So I encourage you to bookmark that one. And then the next site you're also probably very familiar with, but bookmark it if you haven't. This is QualityNet. We do want to just kind of highlight a couple listservs that we would recommend you subscribe to if you haven't already. So I put those in bullet points on the right-hand side. So the HARP Notify listserv, the QualityNet notifications, the CART notifications if you use CART, and then also the listservs for the hospital inpatient quality reporting and hospital outpatient quality reportings. That way you're just staying up to date with everything new that's coming out, whatever kind of communication that that CMS is wanting to trickle down to everybody. You can stay up to date with that there. And then also, as you know, on QualityNet, this is where you'll find your measure specification manuals, the CART tool if you're using CART, and how to register for the HARP account. Next slide. So Elaine, if you don't mind just kind of skimming through each of these, I just want folks to see what's in here, but you can go back and look at these. So I just tried to put some screenshots of how you navigate through CART, how you go about registering for a HARP account, all of the different steps for going through that. And then if you'll keep going. So Amanda had mentioned just if we could include some additional slides for the data submission steps related to OP22, the left without being seen measure. So again, Elena, if you don't mind just kind of skimming through these, but I just wanted folks to see that we have some slides around the description, the definitions as it pertains to the description, and then keep going. So there's two different ways that you can submit this measure. One is via a file upload and one is via data form. So here's just quick instructions that you can see in the bullets. And then down below, I've put together some screenshots for each submission mechanism, depending on which one you're using, so that you can kind of see how that goes. So if you'll just keep skimming through those, Elena, just so that they can see the screenshots. Perfect, thank you. There is a new hospital quality reporting platform coming, so stay tuned for that. And it looks like I think we have just a few minutes left, maybe 7 minutes or so for questions. So I'll just stop there and open it up for questions.
So Courtney, we had one question from Jen Anderson. She's one of our Sparrow Critical Access Hospitals. She was asking about if all patients are screened for all 5 of the S2H measures, and what if they don't answer one of the domains? Are they excluded from the population for declining to answer or unable to answer? And I know Anne said that she would go ahead and email the response to that, but Jen asked for a further explanation, needing suggestions on how to capture when we screen the patient, but they don't answer all 5.
Excellent questions, Jen. I like that so much because I want to write that out so that you guys have that question in writing and then our response. So because that is a great question. So because they break it down into 5, if you're able to get your patient to answer 4 of them, you would be able to, get credit for those 4, and then the one would, because it will be 5 separate measures for each patient. Oh gosh, see, that's so confusing. That's why I want to write it out for you so that it's very clear. And I will get that to you, Amanda, afterwards, so that you can send that out to everyone so they can see the answer to that, because that's a great question. And then along with that, I will look for some tips to how to approach patients. I believe there's resources out there, so I will include that in my response so that they can read about the best ways to work with patients to get those answered. I believe, Jen, that was your question. Let me know in chat if I'm not getting that right.
And this is, can you hear me? This is Jen.
Hey,
Yeah.
hi.
Yeah, no, you did. That's what I was looking for. It's the
Okay.
interpersonal safety question that seems to be the one that, given circumstances, difficult to capture. Sometimes patients just not feeling comfortable responding in front of whoever's in the room with them or whatever, for whatever reason. So that question is the one that seems to get the most, didn't answer, declined the answer, unable to answer kind of responses.
Interesting. Yes, I see that. Thanks for sharing that detail. Yes, I will look into that. That's a great comment.
So with that, so with the 4 of the, if they respond to, we did our part in screening, but they didn't respond to that one question, they would still be counted in the denominator.
Say that again. If they like
leave-
each there'll be 5 different numerators and 5 different denominators.
Yep.
Does that
Okay.
answer that?
But whether or not they fall into the screening category, whether or not, because we screened them, they just didn't answer all 5 questions.
Right. And it sounds like if that patient opt out, they wouldn't be included in the denominator because they opted out.
Of that one question, or for
that one question. Yes. And that's exactly why I want to write this answer out for you, because it's just so tricky. And I want to make sure that you guys are clear on the answer. So thanks for letting me write it out afterwards. And I really appreciate your feedback on that question, and we'll get it to you.
And then we had one other question. I think that Courtney actually answered it through the chat box, but it was for the hybrid measure. Is the clinical submission part electronic, or is there a tool and cart for it? And I believe that Courtney did answer that question.
And I'll just verify too as far as the cart tool piece, but so I'll submit that question and get the exact answer.
Perfect, thank you. In the last 2 minutes, are there any other questions that we want to ask of our RQITA team? And if not, you can always send me your questions. I can get them to Courtney and Ann, and then send the answers back directly to the entire group, because I know if one person has the question, everyone may end up having that question along the line. So there's no other questions. Thank you, Ann and Courtney and Elena, for joining us today. We really enjoyed your presentation. It was very informative. Appreciate the opportunity to speak with you and bring you to the Michigan team. All right, well, if there's nothing more, go ahead, Courtney.
So much. Yeah, I think Ann was just talking too, but she was on mute. But yes, thank you all. Happy New Year. We look forward to working with you all.
Thank you. Thanks everyone for joining. Have a great afternoon.
Have a great weekend.
Right. Yep. Bye-bye.